then I guarantee you your brain is unhappy. And if your brain is unhappy, that's stressful, and the body will make adjustments, including fertility, right? It'll affect reproduction because if the gut's not happy, the brain's not happy, and the brain's like, well, we can't get pregnant now because the gut's not happy and the brain's not happy. So this pregnancy is not a priority.
Welcome to Get Pregnant Naturally, where functional medicine and natural fertility solutions will help you get pregnant and have your baby. Hey everyone, I'm Sarah Clark. My mission is to inspire, motivate, and empower you. And most of all, I want you to wake up. With functional medicine, we can discover what causes infertility and eventually reverse the condition. Today, I'm excited to welcome Dr. Carrie Jones to the podcast. We're digging into hormone balance and the impact it has on fertility. Dr. Carrie Jones is an internationally recognized speaker, consultant, and educator on the topic of women's health and hormones. She graduated from the National University of Natural Medicine School of Naturopathic Medicine in Portland, Oregon, where she's also completed her 2-year residency in women's health, hormones, and endocrinology. Later, she graduated from the Grand Canyon University's Master of Public Health program with a goal of doing more international education. She was adjunct faculty for many years at the National University of Natural Medicine, teaching gynecology, advanced endocrinology, fertility, and has been the medical director for 2 large integrative clinics in Portland. She is the medical director for Precision Analytical, creators of the Dutch hormone test. So check out the Dutch hormone test at dutchtest.com. And before we jump into today's show, don't forget to hit the subscribe button on iTunes or wherever you're listening to this to make sure you never miss a new episode. Hey, Carrie. So welcome to the podcast. Excited to have you.
Thank you. I'm really excited to be here. This is one of my most favorite topics.
Awesome. Yeah. So maybe let me just elaborate on your story and how you came to this field of work.
I know I've known since I was a little kid that I wanted to be in medicine, and I knew that I wanted to do women's health, but I was going down the sort of allopathic MD route. I was pre-med in college, and I got very disillusioned with pharmaceuticals, and I was volunteering in a hospital, and I thought, no, this is not the way that I want to do medicine. I need to figure something else out. And as the universe often does, it moved me from middle of Ohio to Portland, Oregon. And I found naturopathic medicine. And I thought, this is where I need to go to school. This is the kind of medicine I want to do, more integrative, holistic, functional. And so I did. I went to school and focused on women's health, and I did my residency in women's health and hormones, and the rest is history. That's what I keep doing.
Nice. And how did you get affiliated with the Dutch test?
Well, funny enough, I was the medical director of a really large integrative clinic just outside of Portland. There were 9 practitioners, and we had a mix of MDs and PAs and nurse practitioners, naturopathic doctors. And the owner of the Dutch test, I had known from, he worked at a different lab before, and he had branched off and created the Dutch test. And so he approached us and said, can I come present this test to you? And I thought, well, sure, because I'm getting pretty disillusioned with the kind of testing that's out there. I'd stopped doing saliva testing a while ago, and I was using saliva for adrenal, but not for sex hormone. And I was just sort of relying on blood testing. And I thought, gosh, this is really frustrating. So he came and presented, and I thought, ooh, this is a really neat test. So after the fact, I emailed him and I said, I don't know if you need help, but if you need help, I'm happy to help you. And he was just a startup at the time. This was 6 years ago. And he said, well, I have no money, but yes, I need a lot of help because I'll give you hormone tests. And so we just connected, and I did a lot of on the sides work for him and write-ups for him and helped him with ideas. And it just grew into, I became their first consultant and then into their medical director. And now we have a team of 6 naturopathic doctors that work there. So
amazing.
Grown quite a lot in 6 years.
Yeah, definitely. Awesome. So let's kind of dig into some of this testing here as far as the Dutch, but we'll start with, why is it important to test hormones and cortisol and melatonin? Why is it important to test with urine as opposed to blood like most people get?
Right. And actually the biggest reason is you get a much bigger comprehensive picture. So people go get their blood drawn and they get, an estradiol, or they get testosterone, or they get DHEA, and that's it, which just tells one tiny piece of the puzzle. The great thing about urine is that you also get all the markers, we call them metabolites, that have gone through the liver or gone down through different pathways. And when we look at those pathways, we can see like, how does the body process estrogen? Is it processing it through phase 1 detox okay? Is it processing it through phase 2 detox okay? We can see how the body processes testosterone. Like the classic case is your PCOS woman. She says, I have acne and I have facial hair and I'm losing hair on my head and I don't understand what's going on. And maybe her testosterone in blood is normal, but when we do a urine test, we see that she's going down what's called the alpha pathway. And the alpha pathway in research is definitely associated with PCOS. And I'm like, oh girl, the testosterone you do make is going down the wrong pathway, causing all these symptoms, and we can do something about it. Versus if you just got it done in the blood, if you just got a testosterone, and if yours didn't happen to be high, your doctor or practitioner might say, well, I don't know what it is. Your testosterone's normal, but yet you have all the symptoms of PCOS. And so you just get this really big comprehensive picture of what are your main hormones and where are they going? What are they doing?
Yeah, which is important. Yeah. And you talked about, you stopped doing this saliva test. You're just doing that for adrenals, and then you were moving. Then I guess you found the Dutch test. So maybe talk about the difference between a saliva test, such as the adrenal stress index test, and then the Dutch, and why one, like I guess the pros and cons.
Yeah. And I used the adrenal stress index test for years. That was the adrenal test that I used. And what's great about saliva and urine that you can't get in blood is that you can collect multiple times in the day. And so your cortisol is supposed to be really high in the morning to get your booty out of bed and other things. It's anti-inflammatory. It helps reduce autoimmune risk. It helps your blood sugar. And then it goes down through the day, down, down, down. So it's nice and low before you go to bed. Well, it's a pain to get your blood drawn 4 or 5 times during the day. So the saliva test and subsequently the urine test made it really convenient to collect all day so you could see what your cortisol is doing. Now, what saliva doesn't tell you though, is it doesn't tell you your cortisone, which is your inactive form of cortisol. And it doesn't give you, again, what's called those metabolites or metabolized cortisol, which is kind of an indirect way of looking at your total cortisol. So with urine, I can tell people like, how much cortisol are you making in total, which is important, how much of it is free and active, and then how much is getting deactivated to cortisone. Because sometimes what happens is women will get a saliva test, an adrenal saliva test, and her cortisol levels will be super low. And she's like, oh my gosh, I need to do things to stimulate my HPA axis, get my adrenals to make cortisol. When we do a Dutch test or a urine test, I'm like, well, actually you make plenty of cortisol. You're just deactivating it all to cortisone, and that treatment is different. And so I can tell the difference between the two.
Okay. Yeah. And we'll dig into sort of treatments and stuff like that for later. But yeah, that's okay. So that's really the factor. Again, it's just giving more details so that you can give that personalized treatment plan.
Right. Exactly. Especially when you're working with fertility and women come in and they're like, well, I got worked up and I was told that they don't know, it's unexplained.
Mm-hmm.
And then I get the workup, which I'm sure you see too. And it's this very sort of basic, superficial workup. And I'm like, no, there's a whole lot more we can do. This is not fully worked up. And let's try to explain this a little bit more.
Yeah, the unexplained one is so frustrating, right? Because they've just been told everything's fine, and then, well, obviously it's not. So
right, clearly.
So, as far as the Dutch testing, how can it really help someone with infertility?
So 2 ways. One, just like I was saying, it's pretty comprehensive. And so women who are either just starting to try to get pregnant, women who've had recurrent miscarriage, women who have sort of unexplained and they can't get pregnant at all, you get that multiple layer effect. You'll get the pathways, you'll get all the different hormones, you'll get your full adrenal picture as opposed to just part of your adrenal picture. And then you also get some other really neat markers like melatonin and women, which I know we'll talk about later, but women don't realize melatonin, which comes out at night, is actually quite important for fertility. We do some other markers too, like there's your fight or flight marker, norepinephrine, which is noradrenaline or adrenaline. We look at that, which has a lot to do with reproduction. We look at one of the serotonin markers called 5-HIAA, which, helps make melatonin. Serotonin makes melatonin. And so you kind of get this well-rounded look that's a lot deeper than just getting a single blood draw. And then the second way it can be helpful is we actually have a test called the cycle mapping, where women will collect their urine just once in the morning, every day, pretty much every day through their whole cycle, and then we graph it out. And so women who say, gosh, I don't know if I ovulate. I don't know how much progesterone I'm putting out. I get symptoms at ovulation. I get migraines at ovulation and at PMS, sort of that all month long thing where they feel sort of hormonal most weeks of the month. I'm like, okay, we need to do a cycle map and let's graph it out. Like, let's really see what your estrogen and progesterone are doing on a day-by-day basis. So that can be really helpful for women who maybe in a blood draw were told their progesterone is normal, but a blood draw is just one day. We do a cycle map and I can say, yep, that one day it's normal, and then it crashes down. That's a problem.
Yeah, because we normally start with just I guess, I'm not sure the different, I work with a functional diagnostic nutrition practitioner, so she runs all these tests. But we normally start with the one where you collect 5 to 6 days after ovulation. So it's cycle day 19 to 21. So when would you feel it's better to do cycle mapping versus just regular one, I guess?
I would say, so the regular one is called a Dutch Complete. And I would say majority of women just start with that. Like, majority of practitioners are like, let's just get a snapshot. Let's see what's going on. Now, if she comes to you though and says, I have symptoms all month long, or I can't figure out my ovulation. I'm not sure if I ovulate. My temperatures are weird. The, ovulation predictor kits, sometimes they're positive, sometimes they're not. I don't know. If she has a history of recurrent miscarriage, so she's had 1, 2, God forbid, 3, then that's why I'm like, I want to see it all month long. I want to see the entire 28 or whatever day cycle graphed out, because I need to know what your up and down of these different hormones are. So usually just our regular, our Dutch Complete. And then if that's not giving me the answers I want, or she has a much trickier history, then I add in the cycle mapping.
Okay.
And some women just want to know. Some women are like, I want to know what I do all month long. Can we start there? I'm like, sure, of course we can.
Yeah. So they can sort of see when they are ovulating. Sometimes they may not be able to tell, or.
Right.
Okay. And then with that cycle mapping, so then you can get a better treatment plan, or what do you learn?
Yeah, especially I would say, like, the biggest thing that I see, especially in regards to fertility, is that progesterone surge. So women may get a progesterone test through saliva, through urine, through blood on day 19, 20, 21, which is when you're supposed to do it. And then it's normal, but yet they say, I don't understand. I have really bad PMS symptoms, or I have really heavy periods, or I get migraines. I have all these estrogen dominant symptoms, or I had a miscarriage and we think it's due to low progesterone, but yet my progesterone was normal. And I'll say, okay, that's just a 1-day test. And remember, progesterone is supposed to be this really nice, like, rise and fall, kind of like a big hill. So it goes up, right, rounds the hill, and then comes down. But other women go up and down, like a really sharp, they rise really quickly and then they fall just as quickly. So if you happen to test where it's at the high point, it will look high, but it may only be high for a day or two, when in fact I need it to be high for a lot longer and fall a lot slower. And so when we do this cycle map, I can say, yes, you make progesterone. Yes, you ovulate, but we need to extend it out. We need to push it out a little bit, because you're getting the crash, and the crash is resulting in either miscarriage or PMS or heavy periods or what have you. And so because we graph it through the whole month, I can say, all right, in your last 2 weeks, this is what you do. Now let's do something about it.
Okay. And we'll talk a little bit about that a little later in our chat here about some of the things to do. Yeah. So let's dig back into that, the cortisol, so the stress hormone, and the impact on sex hormones. And you talked about the metabolized versus the free cortisol, or you actually talked about cortisone, but maybe kind of dig into that for us.
Yeah, definitely. So, I mean, I totally understand the most frustrating, irritating thing you can tell a woman trying to get pregnant is, well, just relax, it'll be fine.
Wants to slap you. Yeah.
Oh my goodness gracious. Absolutely. But what I think women don't realize is that cortisol and adrenaline, the other stress hormones, they go up for any kind of stress. So if you have inflammation in your body, if you're eating foods you shouldn't be, if you're in pain, if you have infections like gut infections or viruses or Lyme disease, like, all of those tell the body, like, hey, I'm under assault. And then cortisol and adrenaline, noradrenaline, or epinephrine and norepinephrine go up. And so there's this really great quote that I had read in a research study where it said, when the body has really high levels of norepinephrine, which is, again, your fight or flight hormone, then you divert your resources in your body away from repair, away from maintenance, and away from reproduction, and towards things to make you run, right? To make you have fight or flight, to go, to move,
Survival,
which
yeah.
in the short term is fine, right? If you're in a stressful situation, if you're about to get attacked, if you almost get in a car accident, you need those hormones to shoot up so you can move quickly, think quickly, react quickly. But in our society, so many people are in fight or flight all the time, either from infections or from, their gut, or from their food, from the environment, or even from actual stress in their life. And it's diverting resources away from reproduction. And so we see it on urine testing. We see that their cortisol will be quite elevated. We'll see that their norepinephrine marker will be quite elevated. And I can point to that and say, okay, there's something going on in your body, either in your life or in your body, that is causing you to divert away from reproduction. So let's try to address that. Let's try to focus on that.
So it's a red flag to dig in further. Okay.
Absolutely. And then cortisone being inactive, I can also show women when they prefer cortisone. Again, cortisone is not active. So if the body is literally trying to get you to slow down, rest, and heal, I see this often, it will divert into cortisone. You'll have much higher cortisone levels. So I'll say, look, your cortisone is winning because your body is trying to get you to slow down, to rest, and to heal. And if you're focusing on that, then it does become difficult to either get pregnant or maintain pregnancy. So I can see it on paper.
Mm-hmm, mm-hmm. So I'm sorry. So if the cortisone is low, then what does that mean then? Sorry, I missed that.
But the cortisone is low.
Mm-hmm.
It depends what the cortisol then looks like. So again, in fight or flight, the body may push over to cortisol, right? To help you move, deal with stress, handle infection, balance blood sugar, things like that. And so it's a balance back and forth. I mean, this balance happens throughout your day. It can change literally by the second. If you're about to get in a car accident, you will make, a lot of adrenaline and a lot of cortisol. And if you've recently been sick and you're trying to recover, then you will likely make or have more cortisone, convert more into cortisone.
Mm-hmm.
And so it's this back and forth balance. And it sort of depends just, what's going on in her life and then what's been going on lately or long term, because some people will have a preference, a permanent preference. She will permanently preference cortisol or permanently preference cortisone. And then I can say, okay, look, you've got this preference. We need to make some changes. We need to either make lifestyle changes or do some more testing and figure out what is causing this, or add in some supplements, or all of the above to help.
Like you talked about, if there's a diet issue, if there's a food sensitivity or an infection or virus or environmental toxins and all that, even structural stress too. Yeah. Okay.
Oh, completely. Even dehydration. Women don't realize, dehydration is a stress on the body. And so we talk all the time about, drink water, drink water, drink water. And it's so simple. If you're dehydrated, the body freaks out. It gets stressed out. And so it starts with that. Just drink water.
Yeah, exactly. And that affects your egg health and cervical mucus and
yeah.
So it's like, get that stainless steel or glass water bottle and fill it up with filtered water.
Exactly.
So because I've been so open about my experience with the premature ovarian failure, I get a lot of women coming with premature ovarian failure or low ovarian reserve, that low AMH, high FSH. And typically they've been told their only option, like I was told, is donor eggs. And the Dutch is it's very low. It's in the menopausal range. So how does testing help there to figure out a treatment plan?
Yeah, absolutely. Especially with, so with premature ovarian failure and even with like high FSH, things like that, I remind women that FSH, right? It's a communication hormone from the brain to the eggs, to the follicles. And so if there is something blocking the communication, if the brain and the ovaries are not talking that well, then you could potentially have sort of this weird false elevated FSH. And if you make adjustments in diet and lifestyle, and like I was saying earlier, work on gut and, viruses, things like that, you can definitely affect your FSH, which later when we get into, but I can tell a case study, a story of a patient of mine who had a really high FSH, and it was actually had nothing to do with her follicles and everything to do with her health and her lifestyle and the things that she chose to put in her body. But with the Dutch test, it's great because I can see the estrogens, and then I can see where the estrogens are going. So the phase 1 and phase 2 detox, but I can also see things like DHEA and testosterone. So I can see, can you even make estrogen from, do you even have the androgens to make estrogen in the first place? And I can see the cortisol levels, I can see melatonin, I can see, the adrenaline metabolite, and get an idea of how severe is this? And are there other things we can work on? Are there other areas that I see are really blocking this communication between the brain and the ovary, which is great for some women that are just like you were saying, they get this stamp of, hey, you have premature ovarian failure. Sorry, you need donor eggs, but they don't do much workup, right? They run an FSH and an AMH, and you can't get pregnant. And they're like, well, here's your diagnosis. Like, whoa. We haven't looked at hardly anything.
Mm-hmm. Yeah, there's been and it's the same. Most people that come to me, it's not just infertility. When we look further, like you talked about, there's food sensitivities. There's a lot of the time there's major gut infections going on, and stress.
Yeah. And one of my mentors, Dr. Heidi Peterson in school, she was talking about gut infections and fertility. And she said, only one thing can grow down there. She said, so if you have a gut infection, if you have candida, or if you have some sort of bacteria, or if you have, God forbid, worms or something in the gut, then it's hard to grow a baby simultaneously. It's not impossible. It's just harder. And so she said, you kind of got to get rid of one so you can grow the other. I was like, gosh, that's brilliant. That's so true.
Yeah. Yeah, that makes sense. So, and then a lot of people with the high FSH and the low AMH, they may have been told, to supplement with DHEA. And so what's your take on that?
Yeah, there's some good research on that. And I have had, in fact, that case study, I did put her on DHEA. My only hesitation with DHEA is that in the research, the dose is very, very large. To me, I think it's really large. I think it's 75 milligrams, 50 to 75 milligrams of DHEA capsules. And what I see is when women go on that really high dose of DHEA, that they then get anxious or angry or acne or hair loss, and they can't handle it. So they'll do it for maybe a week, and then they call me, or like they've tried it themselves, and they'll call me and go, what's happening? I'm freaking out and I can't sleep and my face is all broken out. I'm like, right, because you're taking man-sized dose of DHEA. And you're probably going down the wrong pathway. And then we do their Dutch test, and lo and behold, yep, they are going down the pathway that causes anger and acne and stuff. So I say, dial it back. We need women-sized doses of DHEA, and let's try to block that pathway so that you don't get the acne, but you do get the benefit of the DHEA on your brain-ovarian communication.
And you'd recommend testing first before you go and pick
I do.
Yeah.
I do, because for some women, even though the research has shown, it's small populations, but they said even women who have normal DHEA levels, giving DHEA can be helpful. But I at least like to know a baseline, like where are we in your normal before we add in DHEA? Don't just run out and take it, so we know what we're working with.
And we talked a little bit about gut infection. So we normally will run the Dutch with the GI map stool test, which looks like the DNA of the stool. And so maybe, you've sort of talked about that you're the mentor that you work with there talked about if there's something going on in the gut, it's very hard to then put a baby in there. Maybe talk about a little bit about gut health and how it impacts hormones.
Well, and estrogen is the big one. Obviously all hormones have to go through some sort of detoxification. And one of the ways you can get rid of it is through your gut. And so you have your microbiome down there. You have your gut bugs, and there's good and bad ones. And unfortunately, if you have an overgrowth of some bad ones, they can make an enzyme called beta-glucuronidase. And beta-glucuronidase is important to help you break down certain things like carbohydrates and flavonoids, which we need. But on the other hand, it also helps re-release estrogen back into circulation. So if you have an upset microbiome, then you are at risk for re-releasing estrogen that's supposed to go out in your stool back into your circulation. It gets absorbed and it comes back around again. And now you have all these estrogen dominant symptoms, again, like PMS, heavy periods, worse endometriosis, tender breasts, mood swings, all because your gut is a mess. But it does it for other hormones too. It may re-release DHEA, it may re-release testosterone. And now you have PCOS-like symptoms, or you have, acne and facial hair and hair loss. And so gut health is super important. And then the gut is directly tied to the brain. There's a nerve, the vagus nerve, that they communicate up and down all day long between the gut and the brain. So if the gut is unhappy, then I guarantee you your brain is unhappy. And if your brain is unhappy, that's stressful. And the body will make adjustments, including fertility, right? It'll affect reproduction because if the gut's not happy, the brain's not happy, and the brain's like, well, we can't get pregnant now because the gut's not happy and the brain's not happy. So this pregnancy is not a priority. And so there's a huge overlap between your hormones and your gut, which I think now thankfully is coming to light, but so many people didn't realize for so long. They thought, oh, like, oh, sure, I have constipation, or I get IBS, or I have gas, or I get heartburn, like, but that has nothing to do with my fertility. I'm like, well, actually it really can. Or not even fertility, just any female stuff that's going on. Any hormonal complaint you have, it can be directly related.
Yeah, and so if you and then someone in with a POF or the low the low ovarian reserve, and as I say, most people we have a gut infection. How do you see then the hormones affecting for them? Because I guess for the estrogen dominant side of things, more like the PCOS, the fibroids, or endometriosis.
Yeah, I see that when you clear up the gut infection, which I'm sure you see all the time, and you clear up the gut infection, like your inflammation goes down, and inflammation just muddies the water of everything in your body. It becomes the focus. That's what the body hyperfocuses on. It doesn't like inflammation, and it's trying to protect you. So when you get rid of those gut infections, when you reduce the inflammation, and even if you don't have an infection, even if you're just eating wheat and you shouldn't be, or dairy and you shouldn't be, or whatever food and you shouldn't be, and it's upsetting your intestines and your stomach, then it affects hormone communication, it affects hormone output. And so now you clear out the inflammation and the body breathes a sigh of relief, and then the communication can happen at a more sort of healthy, natural rate, which is what you want, especially in things where your FSH is high and your AMH is affected, and you may actually not have ovarian failure. Maybe you just had all this inflammation directly impacting your endocrine system, but you won't know until you get rid of the inflammation.
And maybe, as I say, is it a food sensitivity or is it a worm, which can be kind of
Right.
scary, but
I know.
But we've seen it. Okay. And as far as repeat miscarriage, you talked a little bit about that and progesterone levels. What's your take on taking a progesterone cream before testing?
A lot of women do that. A lot of women, either their practitioner puts them on progesterone cream, or they read and put themselves on progesterone cream. And so if you want to know a baseline though, like if you want to know really what your progesterone is, you have to be off the cream for any testing. Serum, saliva, urine, doesn't matter. If you want a baseline, you have to be off your cream. And I also warn women with taking progesterone, just be aware it's ideally taken after ovulation, because if you take it before ovulation, there's a feedback loop and the body goes, oh, I have progesterone, I'm not going to ovulate. I must have already ovulated and made progesterone. So I just warn women, I see it a lot where practitioners say, oh, do progesterone days 12 through 26, or do progesterone days, whatever, 14 through 28. But if you don't know if you ovulate on day 18, then you may suppress, or if you typically ovulate on day 18, then you may suppress your ovulation. So you kind of have to wait until you ovulate and then do the progesterone cream. So you got to match it up with that, which I don't think a lot of women, actually don't think a lot of practitioners realize, but a lot of women don't realize that their progesterone cream may be helping all their PMS and their periods and their endometriosis, but it may not be doing their fertility any good if you suppress ovulation, because obviously we need that egg. That's kind of important.
So in that one, you'd recommend the cycle mapping where you can kind of figure out the exact day of ovulation and then have the cream targeted at the right time. Is that what I'm hearing?
Yes. Yeah, you can definitely do that as well. Now, a lot of people will do just the Dutch Complete, which is just the 1-day test to see for progesterone. But if you want to know, if you really want to get into the fine details of do I ovulate and how strong of a rise is my progesterone, then the cycle mapping is the way to go. You can't really get that at all in blood testing unless you did a blood test of progesterone every day. And that's a lot. It's much easier to pee on a piece of filter paper first thing in the morning and just let it dry. It's easy peasy.
And especially if that repeat miscarriage, which you don't want to happen again. Mm-hmm.
Absolutely. And I'm very much for progesterone, especially for repeat miscarriage. I find that unfortunately practitioners, maybe more traditional practitioners, miss testing progesterone. And that's a key, super easy reason for recurrent miscarriage that we can address and fix and work on right away. And it's safe. You can do progesterone through your first trimester. But I advise women, like, don't just go put yourself on progesterone. I realize progesterone is over the counter. You can get it at Whole Foods, you can get it online. But if you don't know what you're doing and you don't know when you ovulate, you may actually end up worsening the situation. And then you think, oh, this progesterone cream doesn't work. This is junk, when really you just took it at the wrong time. So, work with somebody so you can be very specific, very individualized to you.
Mm-hmm. And as far as estrogen dominance, so which we talked about, so PMS, breast tenderness, mood swings, heavy bleeding, maybe talk about the detox pathways and then the role of folate in there.
So when we make estrogen and we're done with it, we push it through 2 phases of detox, phase 1 detoxification and phase 2 detoxification. And so the phase 1 detoxification is 3 choices, 3 options you can go down. They're called 2-OH, and OH is hydroxy. So the 2-hydroxy, the 4-hydroxy, or the 16-hydroxy pathway. And then the body needs to take those pathways and neutralize them so that it can get rid of them either in your urine or in your stool. And so that's called phase 2 detoxification, when you neutralize them. So folate helps with methylation. Folate, obviously, everyone is testing the MTHFR SNP, which helps obviously with folate production. But really with estrogen, the bigger SNP is a different one. It's called COMT, or COMT.
Mm-hmm.
And so COMT, the SNP, makes COMT the enzyme, which helps get your estrogen from your phase 1 to your phase 2. Now, folate's very important in there. Folate is part of the whole sort of bigger cycle that goes round and round to make that happen, to make that phase 1 to phase 2 push. But with COMT in particular, like magnesium is actually more important for COMT, which is super easy to get. And unfortunately, a lot of people are very deficient in magnesium. But I don't generally start out with folate right away with people. I try to look at that bigger cycle. It's called the methylation cycle, or methionine cycle is what we look at. And a lot of factors go into it: B12, B6, magnesium, like I said, choline, like you get from eggs, trimethylglycine, which is also known as betaine. And so there's a lot of sort of nutrients involved, and there's a lot of SNPs and enzymes involved. But folate can be very important, as we know, just in general with fertility.
Mm-hmm. And then to get to that second detox pathway with the urine and stool, can you just dig a little bit into that for us a little bit more?
How to get into the second detox pathway?
Yeah. So I guess if someone is potentially not eliminating some of these estrogens, I guess, is that what we're saying?
Yeah, so if you are stuck, let's say you get into phase 1, but then now you're stuck, you can't get into phase 2, or it's very slow. The analogy I use all the time is, think of like a big, beautiful clawfoot bathtub. So the water coming into your bathtub is phase 1. So what kind of water is it? How fast is your water coming in? How slow is your water coming in? And then phase 2 is the ability of your drain. Is your drain open? Is it closed? Is it clogged? Is it open but not open fast enough? And so folate and MTHFR, and then more specifically, this other SNP called COMT, or COMT, is what helps dictate whether your drain is open or closed. And then if it's open, estrogen can move out and drain out of your house, just like it drains out of your body. And if it's closed, then all that water builds up in your bathtub and overflows, just like it does in your body. All that estrogen builds up and overflows, and now you're even more estrogen dominant. So getting it out of your body is really helpful. And that's where even things like gut health is super important, because you need to be able to take that estrogen that your body is packaged up and put out into your stool and get it out. So those women who have constipation, or those women who have gut infections, or who have that enzyme I said called beta-glucuronidase, they're more at risk for estrogen problems because they can't get their estrogen out. We want that used up estrogen. Once it's done, we want it out. It's like trash. Take it out of the house.
Yeah, and maybe some simple tips to help with that. If you sort of, I guess, dry skin brushing or cruciferous vegetables or anything.
Yeah, cruciferous vegetables actually focuses more on phase 1 detox, which is perfectly fine. So cruciferous vegetables like broccoli, kale, Brussels sprouts, they contain an ingredient or a constituent called DIM, D-I-M, which stands for diindolylmethane. But it comes from I3C, indole 3-carbinol. And what that does is it helps push the 2 pathway, the 2-hydroxy pathway in phase 1, which is considered the less carcinogenic pathway, the less like estrogen dominant pathway. Another really good one are broccoli sprouts. So not only eating broccoli, but eating broccoli sprouts. Broccoli sprouts, the food, contain these two ingredients that when combined makes sulforaphane. And sulforaphane can help a lot with keeping your estrogens on the right pathway and stopping them from going down the more carcinogenic pathway. So even like not even with fertility, just women who just say, you know, gosh, I have all this estrogen dominant type symptoms, changing your diet to add in broccoli, kale, Brussels sprouts, mustard greens, broccoli itself, cauliflower can be quite helpful at estrogen. Getting fiber up, right? Doing ground flax seeds and hemp seeds and just other in vegetables that are high in fiber to bind up all that estrogen and get rid of it in your stool can make a world of difference. And then just water, just like you were saying with dry skin brushing, which I absolutely love dry skin brushing. Dry skin brushing works a lot on the lymphatic system, and the lymphatic system works on water. A lot of people thought that it's filled with blood, and it's actually mostly predominantly water. And so I tell women, if you want to get that lymphatic system moving, which is where your body dumps all its trash, and then to get rid of it, you got to hydrate. If you're not hydrated, then the dry skin brushing won't work as well, and you'll have a tough time detoxing. So get that water and eat those cruciferous vegetables.
Mm-hmm. Yeah, I was just reading
increase your fiber.
Yeah, I was just reading Dr. Ben Lynch's book, Dirty Genes, and he was talking about the broccoli sprouts in there about eating those. Although he says I haven't actually tasted them. He said they had a kind of a strong flavor.
I do broccoli sprouts pretty much every day.
Oh,
I do not have a green thumb. Everyone's like, oh, just grow them. I'm like, yeah, right. Mm-hmm. So I take them in a powder form, and then they're pretty potent. When I put them in the company I use has a powder and a capsule form, and I happen to have the powder. And when I put it in my smoothie, I can taste it. It's potent stuff, which is fine with me. It's just like a very strong greens taste, but get that taste in the capsules.
Do you have a company that you can recommend there for that?
Yeah, I do. I have no affiliation. The company that I use quite a bit is called Enduracell. Starts with an ENDURA cell, Enduracell. There's another company that I have used also, Zymogen. Zymogen makes, which is XYMOGEN, Zymogen. They have a really great sulforaphane product as well. I just switched to Enduracell because they had the powder, and I always thought, oh, easy, I'll put it in my smoothies.
Yeah.
But I accidentally ordered the capsules this time. So capsules it is. Thought it was powder. It's not.
Cool. So let's talk a little bit about the thyroid issues, such as a lot of people that come to us have hypothyroidism or Hashimoto's and obviously struggling to get pregnant. Yeah. How does the low levels of metabolized cortisol, how does that be connected to thyroid dysfunction?
Well, when thyroid slows down, it slows everything down, right? So we know with hypothyroidism, when slowed down, my hair growth is slowed down, my skin turnover is slowed down, my cycles have slowed down. A lot of women will get either skip cycles, or they'll have long cycles, or they'll have all this heavy bleeding because their ability to shut blood flow slows down. And so it's the same thing with cortisol. Their ability to metabolize cortisol slows down in the liver. And so the metabolized cortisol drops way low. And as a result, they can't metabolize their free cortisol. So their free cortisol goes up. It'll really increase. So in the Dutch test, oftentimes I can pick up a thyroid problem before somebody has had testing. I'll look at their cortisol results and go, hey, I think you need to get some serious thyroid testing, because this thyroid is directly impacting the way your body processes cortisol, which is not healthy. If your thyroid's not working, that's one thing. I mean, that's pretty bad. But then on top of that, if you've got a cortisol issue, you're going to have inflammation problems, you're going to have stress problems, you're going to have blood sugar problems, even like sleep problems. And so we need to get this worked on. And the one thing with thyroid is I always remind or encourage people to get what's called a reverse T3. Reverse T3 is the inactive form of T3. So the body will push to reverse T3, definitely in times of stress, potentially even with like things like inflammation. There's another hormone that the fat cells release called leptin. With high leptin, it will increase reverse T3. And what happens then is that the cells out in your body, the cells in your fingers and your toes and on your ovaries and your skin, miss out on the actual T3 because it's now being all converted into this reverse T3. And when you don't get T3 binding at all these other places, your fingers, your toes, your skin, your ovaries, then you are hypothyroid sort of all over. We call it cellular hypothyroid. But it gets missed because a lot of practitioners will only run the one thyroid marker, TSH, right? Or thyroid stimulating hormone. And TSH is only a marker of what's going on in the brain, in the pituitary. So if your pituitary is perfectly happy, you will have a perfectly normal TSH. But if you're not getting T3 out in your fingers and toes and skin and ovaries, it may not affect, it won't affect your TSH. So you have all the symptoms, and it has everything to do with your T3 out in your periphery, in your cells, and not in your brain. So when you do thyroid, you got to go big. You got to look at a lot of markers in it to understand this.
Yeah, we recommend the full panel with antibodies because and it's even hard for people to get that test run by their primary physician.
I know it's so frustrating. Years ago, I was working with an MD, and we were together, and we were going through chart notes of a patient. I had written down a whole list of labs I wanted, and she, bless her heart, ordered all of them for me, including the antibodies. And then we happened to be together, and we were going through the chart notes, and she said, "Oh, her thyroid antibodies are positive, whatever that means." And I said, "She has Hashimoto's." Yeah. And she was like, "What's that?" Oh. And I mean, this was, in all this fairness, this was years ago, but I thought, how do you not know what autoimmune thyroid is? Mm-hmm. Like, didn't you learn that in school? She was like, "No, we learn the medications, right? Levothyroxine, which is, or Synthroid, which is T4. Yeah. And that's what we learn. Like, we learn if it's thyroid, if their TSH is high, put them on Synthroid. We don't learn any of the pathophysiology, like, really." And so I explained what Hashimoto's is. And now, I mean, she's totally on board and she understands it completely. And all her patients, she treats functionally for Hashimoto's, but it was such the norm. I mean, it's still the norm for a lot of people to go, still the norm. Who cares? Who cares if your antibodies are high? I'm still putting you on Synthroid. I'm like, oh, okay, but you just missed a huge piece of the puzzle.
Because it's kind of the thyroid, the canary in the coal mine.
Yeah.
Of other things out of balance. Yeah.
Yep.
Can you talk a little bit about low melatonin and what that would mean for fertility?
Yeah. So melatonin is made, believe it or not, primarily in the gut. And then it's made a little bit in your brain, in your pineal gland. It's your hormone that comes out at night, whereas cortisol is the day. Cortisol is like your sun. Melatonin is like your moon, comes out at night. But melatonin sets rhythms. It sets the circadian rhythm. So you can get up in the morning and go to bed at night. But it also is super impactful for your reproductive rhythm. So for those women who say, "I have irregular cycles," or "I don't think I'm ovulating," or "I haven't had a cycle," or some cycles are 21 days long, some cycles are 40 days long. First thing I always say to them is, how is your sleep? How is your sleep? Because it's melatonin that's really helping direct your rhythms. And if you're not sleeping in darkness, if you're, sleeping with your phone right next to you and it's light and it's bright and it's keeping you up, if you're on your phone at night or your tablet or your e-reader and you're getting all that false blue light that's emitted from the screens, you'll screw up your melatonin, and then the melatonin in turn screws up your rhythms. So your sleep rhythm, but also your reproductive rhythm. So that's a big one for melatonin. And then of course, melatonin is a very potent antioxidant. It's important for egg health. And so I don't think women realize that when they sleep, when their melatonin goes up, it's actually really good for egg quality and egg health. So we want that melatonin. We want to keep it produced out of the pineal gland.
Yeah, I just did a podcast actually with talking about egg health, and she was talking about the importance of melatonin. Would you test that first in the Dutch as far as where it is? Because it can also be an indicator of a gut infection too, can it, if it's low?
Usually it's high. It's the other way. So usually we'll see higher melatonin with the gut infection. Yeah, in that case, you take symptoms. Sometimes people will say, "Why is my melatonin high? My patient's not taking melatonin." And I'll say, "How is their gut? What's going on with their gut?" Because it's an antioxidant in the gut as well. And so it will go up with gut infections. And then in general, I do say, yes, test before you take it, just to see where you are, to see how low you are. And if you choose to take melatonin, make sure you're at least addressing the cause. So many people just go on melatonin, but they stay on their phone at night, or they stay up at night, or they're doing all this activity, they're drinking at night and eating sugar, and they're all wound up, and then they try to go to bed and they think, "Oh, I'll just take melatonin, I'll be fine." Like, well, you're still not addressing the cause. You're still screwing up your rhythms. You're just supplementing with melatonin. It's a rhythm thing. Go to bed. Get off your phone and go to bed.
Invest in those little light blockers, the blue light blockers. Yeah.
I have those sexy little glasses. Yeah.
I know
With my red.
I know they started popping up for me on my Amazon. I'm like, have you bought these blue light blockers yet? I'm like, well, maybe I must have looked at those. I'm like, it's time to get them.
It's always scary though. Is that scary when you're talking about something and all
You're
of a
like,
sudden it shows
why is
up
that
in your
there?
ads? I
I
know.
don't
You're like, I know you're listening. Don't tell me you're not.
know. So a lot of women that we work with, well, first of all, dealing with anxiety from infertility, but they also may have been dealing with anxiety for, years and years and consider themselves an anxious person. And then as we go through all of this, we figure out that that's not the case at all. But how is anxiety and not being able to sleep? You just talked about sleep there, but how does that connect to fertility?
Usually, believe it or not, it's tied significantly to progesterone. So progesterone gets broken down into metabolites, and you have an alpha metabolite and a beta metabolite. So the alpha metabolites of progesterone can cross the blood-brain barrier, and they support your big anti-anxiety hormone called GABA. So GABA, when those receptors are stimulated, you feel calm and relaxed and happy, and you can sleep. And so when women produce healthy levels of progesterone and they can make a lot of the alpha progesterone, the alpha metabolite, they feel less anxious and they tend to sleep better. So we see this with women who go on progesterone. Now, usually it's oral progesterone that works the best, followed by the dissolvable or sublingual type progesterone. We don't see it as much with the cream. And the reason for that is the way that the liver processes the oral or the sublingual is different than the way it processes the cream. But some women for sure get anxiety and sleep relief with the cream, with the topicals. But they go on it and they say, oh my gosh, I feel less stressed. I feel less anxious. I sleep so much better when I take this at night. And I'm like, yep, progesterone. And it can also be a neat little test for women who think that they're making enough progesterone, and then they go on progesterone and they actually feel so much better. Their anxiety goes away and their sleep gets better and their PMS reduces. I'm like, well, you must be one of those people who ovulates and then subsequently makes progesterone, but just not enough. Your corpus luteum or corpus luteum is just not strong enough for you. And that's why the supplementation helps so well.
Hmm. And then you did talk about like going through a case study. Do you have time to share that with?
Yeah, I do. This was years ago, when I first got into practice. I had a woman come in. She was in her 20s and she was newly married, and she had her FSH was also in the 20s. And she was like, my husband and I want to get pregnant, but my FSH is double digits, really high in the 20s. And I was told I have premature ovarian failure and I'm freaking out. And they want me to do all this stuff, this intervention. I don't want to. I don't know what to do. And it come to find out, much like a lot of our talk, she had a really bad dietary habits. She did a lot of fast food. She didn't eat consistently. She had a very high stress job. Nobody had ever really taught her about health or her cycle. Like, she wasn't tracking her cycle. She didn't know if she ovulated. And then she had a lot of GI issues subsequently from eating a lot of fast food and not being the healthiest. Like, she was like, oh, I was diagnosed with IBS as a teenager. Like, yeah, I have IBS. And so I thought, you're awfully young to have a really high FSH, and you seem to have a lot of things going on. Like, why don't we work on all these things? And then, because I know FSH is just a communicator, let's come back to it. So we worked for several months on her, and it was really neat to watch her FSH drop from like the 20s to the teens. And then all of a sudden it was in the single digits and she got pregnant. And so I'm not saying this, of course, happens for every woman, but in her case, I just had this really strong, no pun intended, gut feeling that it was just all the choices she was making was directly impacting the communication from the brain to the ovary. And so once we cleaned up all her inflammation, basically we cut all those foods out and worked on her stress response and got her gut healthy again, then, the factory could work again, and her FSH dropped significantly. And I know FSH is not the only thing that goes into fertility, but it was a great marker to see drop down over the months. And we were, it was super exciting every time, where she'd go from the high 20s to the low 20s to the high teens to the low teens. And then she was in the single digits. And so
that's amazing.
So that was a really, really fun case study. And then she got pregnant, which of course was fantastic. So it just goes to show lifestyle, infection, inflammation, all that stuff for sure plays a role.
Yeah, it's all connected. She was still cycling naturally.
She was, but it was kind of, I would say, well, do you have a cycle every 28 days? She's like, I don't know. I just get my period. I'm like, okay.
That sounds like me. It
Let's
was like it's a couple times a year. I'm like, I don't know when it comes. I've got no clue.
right. I'm like, let's start tracking this a little bit better. She just wasn't, and to no fault of her own, she was just never taught. Nobody ever, she never got this education, and her family didn't teach her the school, she didn't get it in school. And so I did a lot of just basic education on what the menstrual cycle is and how to track it and what we're looking for. And then she was super excited and she felt really empowered. She could track these things and understand these things.
Yeah. And again, the clue with the IBS, which seems to be the kind of the all encompassing, oh, wait, there's something going on in the GI tract. It's IBS.
Right. Always. Right. And so it's so common, I'll say, women will say to me, oh, I was diagnosed with IBS years ago. I definitely have IBS. I'm like, well, what are you doing about it? They're like, oh, nothing. I have IBS.
Yeah, I'm suffering. Yeah.
I know, exactly. And I thought, oh gosh, all these years you've been left to handle something that maybe we could have done something about years ago.
That's right. So as far as any resources you'd recommend, a book or a website or an app, anything you like, documentary?
Yes. Well, I was going to say with documenting, I just tell women, again, I have zero affiliation, but I know a lot of women do apps, they'll track their temperature. They'll use something like the Daisy, they'll do the OvuSense or something like that. You got to get in tune and in touch to understand, are you 28 days? Are you 31 days? Are you 27 days? Do you go back and forth? And especially because your right ovary and your left ovary are sisters, not twins. And so righty might be doing something completely different that month. And then lefty's done something different that month, the month that lefty goes. And I tell women that even though we're all taught that the ovaries ovulate back and forth, right, left, definitely doesn't always happen. And a lot of women, when I tell them this, they'll go, oh, you're not kidding. I feel like it's one-sided for a while and the other side goes. I'm like, yeah, that's what can happen. You'll have very typical cycles, 1, 2, 3, and all of a sudden you get this freak cycle and you're like, where did this come from? Like, it's possible you are one side dominant and then the other side went shot off. And so, but if you don't track, you won't know that, if you don't watch your temperature or your symptoms or the length of your cycle and the days you bleed, do you ovulate, then you'll never know. And if you know all this stuff, then you can be empowered to do something about it. And then the other thing I recommend is following there's some great fertility experts, online that I absolutely love. Again, I don't have any affiliation. I just like what they put out. So one is Dr. Jacqueline Chassie, who's on the East Coast, and the other is Angela Heap, which she's in the UK. And they put out really great, just basic fertility information that can be really helpful. And even I love listening to both of them, because even as long as I've been doing fertility, I'm like, oh, I didn't know that. Oh yeah, that's right. I'm like writing down little notes like, oh, right, of course.
Oh,
so finding
Jacqueline Chassie, is that CHASY?
CHASSE.
SSE.
Yep. And Angela Heap, HEAP.
Okay, great.
And they're both on social media. I follow them on Instagram because I'm a visual person, so I like all the pictures.
Thank you. Awesome. And anything else you want to recommend? Or so we got the Daisy, the OvuSense, so Dr. Jacqueline Chassie, Angela Heap. I think those are some great recommendations.
Yeah. And I'm sure I know, and with your podcast, there's so many recommendations that have been made, but those are just some little extra ones for people.
Awesome. Thank you.
Yeah.
And so you are offering our listeners a coupon code for $50 off a Dutch test, and they can use the code Get Pregnant, and you go to dutchtest.com. Did you want to share anything about that?
Yeah. So, well, first of all, I want to tell people that Dutch is an acronym. We do not test for Dutch heritage. Which we get asked a lot. Like, oh, I'm like, I know you're not Dutch. I got it. It's dried urine test for comprehensive hormones. So there are these pieces of filter paper that you will urinate, kind of like a pregnancy test. You just stick it down there, urinate on it first thing in the morning, 2 hours later, around dinner and before bed. So we have different filter papers, and then you'll let them dry and mail them back to the lab. So when you go to dutchtest.com, we have several options, but the coupon in particular are for our Dutch Complete, which is what we've been talking about. And then we have a new one called the Dutch Plus, which is an adrenal, more focused test. So you get all the same hormones, everything we've been talking about, and you get additional adrenal markers on top of all the markers we've already said. And so when you choose which test you want in the coupon code section, you'll just type in "get pregnant" and you'll get $50 off.
Excellent.
Yeah.
Amazing. Well, thank you. Yeah. And thanks for joining us today, sharing your words of wisdom and kind of a down to earth approach as well. So it's quite accessible for people. So thank you again so much for coming on the podcast.
Yeah, I really appreciate it. This was a lot of fun.
Awesome. Thank you. Hey there, Sarah Clark here. So are you struggling to have your baby? First of all, please know that my heart goes out to you. I support couples worldwide who are struggling with infertility to conceive and have healthy babies. Women like Rita, who gave birth to her beautiful daughter after following my fertility coaching system. Or Danielle, who after 2 failed IUIs was able to get pregnant after a Supercharge Your Fertility discovery call with me. So here's how you get my help for free. So I offer a free Supercharge Your Fertility discovery call. And on that call, I'll create a plan with you that is going to help you fast track your success. So this call is not for everyone. And I'm really picky about who I get to speak with. And I have a strict but totally reasonable criteria that needs to be met in order for us to move forward. So here's who I can help. So first of all, you need to be able to explore your infertility diagnosis in a new light. So this offers for people who are open-minded, they're coachable, and if you can do that and want to double or triple your chances at the fertility clinic or get pregnant, awesome. So let's get on the phone and chat. Also, you must be an action taker. So someone who's committed to seeing results, you're able to follow directions. Don't worry, I'm not going to ask you to do anything bizarre. But if you're one of those people who like to consume a ton of information, but don't like to spend time implementing and seeing results, then the call's not really for you. So I only want to spend time with people who are genuinely committed to their own success. So just click on the link in the show notes and apply, or go to fabfertile.com and click on the free consult. So it's a really short application that just tells you about your health, how long you've been trying to conceive, and how soon you'd like to be pregnant. So seriously, this is going to be the best time you've ever spent on your fertility. Looking forward to chatting. Talk soon. Thank you for listening to Get Pregnant Naturally. Seriously, it means the world to me that you're here. Make sure you hit the subscribe button so you can be notified of upcoming episodes. I'm excited to offer you a special gift. If you're a U.S. resident, text FERTILE to 345-345. You'll be prompted to enter your email address and you'll receive our fertility yoga download. In this 20-minute intro video, we focus on a calming and peaceful practice to connect back to your heart. These simple fertility yoga poses can help quiet negative thoughts and make you feel more in control. Download it now and get started today. So for U.S. residents, text FERTILE, FERTILE, to 345-345. For non-U.S. residents, go to www.yogafreebie.com to access your special gift. That's www.yogafreebie.com to access the free fertility yoga download. And I love this quote by Dr. Mark Hyman, medical director of the Cleveland Clinic Center for Functional Medicine and chairman of the Institute for Functional Medicine. Functional medicine is medicine by cause, not by symptom. Functional medicine practitioners don't in fact treat disease. We treat your body's ecosystem. We get rid of the bad stuff, put in the good stuff, and because your body is an intelligent system, it does the rest. Thanks for listening. Until next time.